This recording is part 3 of the anatomy of the nervous system. Now that we've looked at the central nervous system, we're going to go ahead and look at the peripheral nervous system, which includes everything that's not in the central nervous system, with the exception of the soma, which you remember are the nerve cell bodies, in the anterior and lateral horns of gray matter in the spinal cord, because those neurons have axons that are going to exit through the ventral root to form nerves that are going to travel away from the central nervous system to the periphery of the body. In the central nervous system, anytime we spoke of a collection of soma in the central nervous system, we had two different terms that we could use. One was nucleus, and the other was ganglion. We saw the basal nuclei, for example. Now, in the peripheral nervous system, we only use the term ganglion. Ganglion is the singular form of the word. Ganglia would be plural. So a ganglion is a group of neuron cell bodies, which you know are soma, found in the peripheral nervous system. These neuron cell bodies can either have sensory or autonomic functions. We know that ganglia are simply groups of soma or neuron cell bodies, which is why the structures have an enlarged appearance. Here we have a dorsal root ganglion on this side of the spinal cord, and you'll notice one on the other side as well. Ganglia can either be sensory or autonomic in function, and with these sensory unipolar neurons, you'll remember that there are sensory endings, and there's a fiber with that unipolar attachment. Here's the soma, and then the fiber continues to synapse with a second order neuron, because this would be the first order neuron. And there's usually 3 neurons involved in getting information up to the primary somatosensory cortex of the brain. A lot of books refer to this length of this sensory neuron as one axon, because it bypasses the soma, it bypasses the cell body. So when you see this sentence that axons end in the periphery, well, this end on the left is where we have the dendrites, but a lot of books again will call the entire length after the dendrite the axon. And so we have axons in the periphery of the body away from the central nervous system. And we can also see in this picture that there are other ganglia involved in the body. We have ganglia associated with cranial nerves. Here we have the trigeminal ganglion and the submandibular ganglion, the pterygopalatine ganglion. This is to say that there are ganglia located throughout the body. So with cranial nerve ganglia, these are specific collections of soma associated with the 12 pairs of cranial nerves that we'll discuss in just a bit. And they're located outside the cranium, and all of these are basically unipolar neurons, because these are all sensory neurons that are involved with these ganglia. This takes us to more ganglia that are located in the peripheral nervous system. There is a chain of ganglia known as the sympathetic trunk ganglia or sympathetic chain ganglia, associated with the sympathetic portion of the autonomic division of the nervous system. Remember, the sympathetic nervous system is that fight-flight portion of the autonomic nervous system. And the sympathetic trunk or sympathetic chain are sometimes also called paravertebral ganglia because they are found lateral to the vertebrae. There are also other ganglia that you can see here in front of the abdominal aorta, and these are referred to as collateral or prevertebral ganglia because they're located in front of the vertebrae and are located also near the abdominal aorta and other major arteries. The adrenal gland is made up of two portions. There's an outer portion, which is the adrenal cortex, and an inner portion known as the adrenal medulla. And the medullary portion of the adrenal gland also has a sympathetic function. They function like sympathetic ganglia. However, they release neurotransmitters into the blood. They're not technically sympathetic ganglia, but they have a similar function. We talked about the autonomic nervous system having a sympathetic division, which is the fight-flight. And there's also a parasympathetic portion of the autonomic nervous system, which is the food, mood, feed, breed, rest, and digest. Parasympathetic means around the sympathetic. So the sympathetic nervous system basically is coming off of the spinal cord between T1 and L2. Para means around, and the parasympathetic nervous system has fibers that are coming off of what's known as the craniosacral area. And so para meaning around, well, it's around the sympathetic. We have the parasympathetic. The parasympathetic nervous system includes terminal ganglia. So here we see the ciliary ganglion, the pterygopalatine ganglion, the submandibular ganglion, and the otic ganglion. And then there's another type of ganglia within the walls of the organs, and these are called intramural ganglia. So, for instance, let's take the submandibular ganglion. This is a terminal ganglion, and then there's another neuron that's going to synapse with a ganglion in the wall of the submandibular gland. So, intramural within the wall. The way I remember this is if you go to the bus stop, you'll see murals on the wall. So the bus stop has to come first. Terminal means end. So the bus terminal would be the bus stop. When we look at a nerve plexus is basically a network of axons, which are nerve fibers. And here we have the brachial plexus, and here we see on the right-hand side there is a lumbar plexus and a sacral plexus. So what happens is that as fibers come off of the spinal cord, they will intermingle and mix to form different structures and then branch apart and come together and branch apart. And we see that in this network of nerve fibers that make up a plexus. Cranial nerves are named so because the first two pairs of nerves attach to the forebrain and the rest emanate from the brainstem and part of the spinal cord. The cranial nerves serve the head and neck, with the exception of the vagus nerve, which actually goes into the thoracic and abdominopelvic cavity. If we look at the cranial nerves here in this picture, if you look closely, you'll notice that they're numbered, and they're numbered with Roman numerals. You should be able to know how to write out Roman numerals 1 through 12. And whenever we speak of cranial nerves, we not only know the name, but we know to abbreviate the name by its number. So if I was going to write out cranial nerve, let's pick on 5, which is trigeminal, I would write it this way, CN5 with the Roman numeral to indicate the trigeminal nerve, which you can see here. So we're going to take a closer look at the cranial nerves and their functions. We're going to begin with the olfactory nerve. If you remember, the cribriform plate of the ethmoid bone had tiny little holes called olfactory foramina. Here we see those terms again. You see the cribriform plate of the ethmoid bone. And those tiny little holes, the olfactory foramina, allow for the filaments of cranial nerve 1, which is the olfactory nerve, to go from the nasal cavity through those holes to synapse with a structure called the olfactory bulb. And the olfactory nerve fibers, again, are basically coming from olfactory sensory neurons located in the epithelial tissue that lines the nasal cavity. And after those fibers go through the olfactory bulb, the neurons will extend posteriorly as the olfactory tract, and that will go beneath the frontal lobe to enter into the cerebral hemispheres, terminating in the primary olfactory cortex. And the only information that's carried on cranial nerve 1, which is the olfactory nerve, is the sense of smell. Cranial nerve 2 is the optic nerve, and you'll notice that there are fibers, if you look closely, there are fibers that emanate from the lateral aspect of the eyeball as well as from the medial aspect of the eyeball. And the fibers on the medial aspect are the only ones that cross at this structure known as the optic chiasm or optic chiasma. The lateral fibers stay on the same side. So here's lateral fibers. They're going to stay on the same side. Only the medial fibers cross at the optic chiasma. And what happens is, as the optic nerve exits as axons coming from the back of the eyeball, the retina, and crosses, once it crosses the optic chiasma, the collections of fibers are referred to as optic tracts. From there, the neurons will synapse with neurons in the lateral geniculate nucleus of the thalamus, where they become optic radiations that enter the primary visual cortex. That's where visual sensation occurs, in the primary visual cortex of the occipital lobe. And remember, there's a visual association area that will help a person determine what he or she is seeing based on past experiences. For instance, I might look at a doorknob that's different from any other doorknob I've ever seen. However, due to my experiences in the past, I know that I can use that mechanism somehow to open the door, whether it's pushing down on it or turning it, or even grabbing it and pulling it or pushing it. I use my visual association area to help determine what sensory input I've received. If there's damage to the optic nerve, that can result in blindness to the eye where the optic nerve has been damaged. So if this optic nerve is damaged, then this eye would have resultant blindness. If there is damage to the optic chiasma, where the medial fibers cross, the medial fibers actually pick up peripheral vision. And so that will create a loss of peripheral vision, which is referred to as bilateral hemianopsia. So there are different things that can happen when the optic nerves are affected. If a person has glaucoma, where pressure builds up from the fluid just inside the eyeball, that can also press on the optic nerve. That's a condition known as glaucoma, and that can also cause blindness. The oculomotor nerves have fibers that are going to extend from the ventral portion of the midbrain near where it joins with the pons and extend through the superior orbital fissure, and they are basically going to innervate 4 of the extrinsic eye muscles. Now please know, I'm not going to ask you on a test where these fibers are coming from. That's not the most important thing. What I really want you to get with all of the cranial nerves is know the name, know the number, know where they innervate, the structures that they innervate, as well as the functions. So for the oculomotor nerves, which we're looking at cranial nerve 3, these nerves innervate 4 of the 6 extrinsic eye muscles. And remember, there are 4 that go straight. You've got superior rectus and inferior rectus, and then medial rectus and lateral rectus. There we go. Medial rectus and lateral rectus. Superior, inferior, medial, lateral. And then there's 2 that go at an angle. So you've got superior and inferior oblique. The extrinsic eye muscles have a really handy formula that will help you remember what cranial nerves innervate which muscles. So as long as you know all the muscles and you remember SO, which stands for the superior oblique muscle, 4, and then LR, which stands for lateral rectus, 6 over 3. That means that all the other extrinsic eye muscles are going to be innervated by cranial nerve 3 oculomotor. So SO4 stands for superior oblique, is cranial nerve 4, which is the trochlear nerve. LR6 is lateral rectus, which is going to be innervated by the Abducens nerve. We'll get to those. And then all other extrinsic eye muscles. So what else is left? If you know them all, you can figure out, well, I've got superior rectus, inferior rectus, medial rectus, and inferior oblique would be the remaining muscles. So again, 4 muscles that are straight: superior rectus, inferior rectus, lateral rectus, and then medial rectus, 4 straight muscles, and then 2 at an angle, superior oblique, inferior oblique. If you can learn those and then remember this formula, it will keep you straight in terms of what muscles are innervated by these cranial nerves. So let's see some of the things that the oculomotor nerves do. We know it's going to be somatic motor to 4 of the 6 extrinsic eye muscles. And they're listed here. Again, if you can remember the muscles and remember the formula, you can pretty much figure it out pretty easily. They also go to a muscle that helps to raise the upper eyelid called the levator palpebrae superioris muscle. And there are parasympathetic fibers to the sphincter pupillae muscles, which are the circular muscles of the iris, which is the colored portion of your eye that helps the pupil constrict. And there are also fibers that go to the ciliary muscle, which controls the shape of the lens for focusing. There's also some sensory proprioceptors that give the brain information on the position of the eyeball. So let's see. This takes us to the trochlear nerve. Okay, the trochlear nerve is motor to superior oblique. Trochlear nerve is cranial nerve 4, and it's motor to superior oblique. It's part of that SO4, superior oblique, 4, trochlear nerve, LR, lateral rectus 6, we'll see the abducens nerve later, over 3. So primary function is of the superior oblique muscle is to move the eye downward and laterally. It's opposite what you think it would be. It doesn't go up, it goes downward and laterally. Inferior oblique goes up and laterally. Superior oblique moves the eyeball down and laterally. So if it's damaged, you can't look down and laterally. It may cause double vision. I'm not really concerned that you know that as much as know that cranial nerve 4, the trochlear nerve, is going to innervate superior oblique to move the eyeball down and laterally. This takes us to cranial nerve 5, which is the trigeminal nerve. If you hold up your hand with your 5 fingers and put it over your face, you'll notice that there is an area that goes around your eyes, and this would be the ophthalmic division, which conveys sensory impulses from the skin of the anterior portion of your scalp, eyelids, nose, nasal mucosa, as well as the cornea and the lacrimal gland. And then the maxillary division, which runs, here over the maxilla, is going to also convey sensory impulses from the nasal cavity mucosa, the palate, upper teeth, skin of the cheek, the upper lid, the lower eyelid, and then the mandibular division is going to go over the mandible, and that will convey sensory impulses from the anterior portion of the tongue, except for taste buds, the lower teeth, the skin of the chin, the temporal region of the scalp, and it does have motor fibers to muscles of mastication. Okay, motor fibers to muscles of mastication come from the mandibular division of the trigeminal nerve. Okay, here we can see the ophthalmic, the maxillary, and the mandibular divisions of the trigeminal nerve, cranial nerve 5. And again, motor to muscles of mastication. Remember, muscles of mastication include the medial and lateral pterygoids, the temporalis, and the masseter. And it's sensory for pretty much your entire face, your nasal cavity, and tongue except for taste. And the cornea, which is, by the way, since a lot of you haven't learned this portion yet, the cornea is the clear part over the colored portion of your eye. The white part is the sclera. Trigeminal neuralgia, or tic Douloureux, is inflammation of the trigeminal nerve. Usually there's a ganglion, the trigeminal nerve ganglion, and that's usually what's affected. And this can cause a lightning bolt of pain. So a person who has tic Douloureux might have severe excruciating facial pain that lasts anywhere from seconds to minutes. It can be triggered by contact with the lips, tongue, gums, usually due to a blood vessel pressing on the nerve, and they often address severe cases by either moving the vessel or destroying the nerve altogether. Tic Douloureux is known as being so severely debilitating that sometimes it can cause people to feel suicidal. So here's a picture of a person experiencing that trigeminal neuralgia. Most cases of trigeminal neuralgia, by the way, tend to be in males who are younger and is alcohol related. This takes us to cranial nerve 6, which is the abducens nerve. Remember SO4LR6. The L stands for lateral and the R stands for rectus, because this is motor for lateral rectus muscle. So abducens, remember abduct, take away from midline. So here, I'll do this for you guys. That's the lateral rectus muscle that moves the eyeball laterally. The facial nerves, cranial nerve 7, is going to give you sensory information for the sense of taste, for the anterior 2/3 of the tongue, where you taste things like sweet, salty, sour, bitter, and umami. And it's going to have motor information for muscles of facial expression and autonomic motor impulses for lacrimal, nasal, and salivary glands. My nasal motor autonomic glands are very active. You can hear it in my voice. Bell's palsy is inflammation of the facial nerve, which you know as cranial nerve 7, most commonly due to infection with herpes virus, but could be due to other things. And with Bell's palsy, there's paralysis of the facial muscles and loss of taste on that side of the tongue. Also, it's commonly noted that the eyes may be watering, drooping, the eyelids can't close completely, corners of the mouth may droop, and is most commonly treated with corticosteroids. Most people who get Bell's palsy experience a complete recovery, at least in about 70% of the cases. Some people who have Bell's palsy may have residual effects that are not as severe as they were when it was initially occurred. This takes us to cranial nerve 8, which is the vestibulocochlear nerve, because there are some branches of this nerve that are coming from the vestibule of the inner ear. And so we have a vestibular nerve, and then we have a cochlear nerve arising from fibers that emanate from the cochlea, which is this snail shell appearing structure in the inner ear. And these two nerves join together to form the vestibulocochlear nerve. And the vestibular portion gives us our sense of equilibrium. the cochlear portion gives us a sense of hearing. Cranial nerve 9, glossopharyngeal nerves, are going to be both sensory and motor. They're sensory for the sense of taste, pain, touch, temperature, pressure from the pharynx and the posterior 1/3 of the tongue. There are special chemoreceptors and baroreceptors in the carotid arteries. There are chemoreceptors that monitor the concentrations of oxygen and carbon dioxide in a structure known as the carotid body, and the carotid sinuses have receptors for blood pressure. And so that information is going to be carried on the glossopharyngeal nerves as well. Cranial nerve 9 is also motor for the tongue and pharynx for swallowing, and has autonomic motor information going to the parotid salivary glands. Cranial nerve 10 is a cranial nerve that descends through the neck region and goes into the thorax and the abdomen, so it's often referred to as the wandering nerve. It's got motor fibers that will go to the heart, the lungs, the abdominal organs, as well as to the pharynx and the larynx. It has sensory fibers carrying information back to the brain from the thoracic abdominal viscera, and also includes baroreceptors in the aorta, which is the biggest blood vessel coming off the heart, as well as the carotid arteries. Cranial nerve 11 is the accessory nerve, and this is the only cranial nerve that has fibers that come off of, or rootlets that emerge from the spinal cord at the levels of C1 through C5. You can see these little rootlets on the right-hand side of the picture above. And the spinal accessory nerves, or just accessory nerves as they're now referred to, are going to supply their motor for trapezius and sternocleidomastoid, and they're also sensory proprioceptive sensation for those same muscles. So the accessory nerve, cranial nerve 11, is going to be both sensory and motor for trapezius and sternocleidomastoid. This takes us to cranial nerve 12, which is the hypoglossal nerve. The hypoglossal nerve is going to be motor to the tongue, so moving the tongue around, and also sensory for proprioceptors to the tongue muscles. Remember, there are 31 pairs of mixed spinal nerves. There are actually 8 cervical nerves. You remember there are only 7 cervical vertebrae. However, the first pair of cervical nerves comes off of the spinal cord above atlas, which is C1. Then we have 12 thoracic, 5 lumbar, 5 sacral nerves, and 1 coccygeal nerve, for a total of 31 pairs of mixed spinal nerves. You'll notice that off of the spinal cord, not only do we have these spinal nerves, but you'll see that there are networks that form from these nerve fibers as they may converge and form other structures and then split apart and converge again. So we see in this picture that there is a cervical plexus, a brachial plexus, a lumbar plexus, and a sacral plexus. When we look at spinal nerves, remember that a spinal nerve forms from the convergence of a ventral root with a dorsal root. Here we have the dorsal root ganglion, posteriorly, and here we have the ventral root. Dorsal root and ventral root combine to form a spinal nerve. Did you notice the sympathetic chain ganglion here and here, as well as on the other sides of this picture? The ventral roots are arising from motor axons or nerve fibers that are coming from soma that live in the ventral horn of the gray matter of the spinal cord and extend to skeletal muscles. Remember, they are lower motor neurons because there are only two neurons involved in skeletal muscle contraction. We have an upper motor neuron that resides or has its soma in the primary motor cortex, which is going to have an axon that goes down the length of the spinal cord, usually crossing to the other side of the body, to synapse with a lower motor neuron. The dorsal roots contain sensory fibers, and remember that the dorsal root ganglion is where the soma or cell body for those neurons resides. The dorsal root is going to conduct sensory impulses to the posterior horn of gray matter in the spinal cord. When we look more closely at the convergence of the dorsal root and the ventral root, here's the dorsal root, here's the ventral root. How do I know just by looking? Well, I can see the dorsal root ganglion right there. They converge to form a spinal nerve. The spinal nerve is not in and of itself a very big structure because the spinal nerve quickly branches out. Remember, the word ramus means a branch-like or arm-like extension coming off an angle? Well, there is an angle formed here, and we find that there is a dorsal ramus and a ventral ramus. The dorsal ramus is going to carry somatosensory and motor fibers innervating the skin and the skeletal muscles of the back. They do not get involved in forming any of the plexuses that we just saw on the previous slide. The ventral rami are going to carry somatosensory and viscerosensory as well as motor fibers that innervate the skin and muscles of the front and sides of the body as well as the limbs and the organs inside the body. If you look at one of the two models of the spinal cord in the lab at the Marietta campus, you'll notice that the dorsal ramus is very tiny coming off of the spinal nerve, whereas the ventral ramus is much thicker. Well, it makes sense if you think about it. I've got a lot more stuff anteriorly on my body. I've got organs, I've got muscles, I've got skin, so much more stuff going on in the front than I have in the back. So it makes sense that the ventral ramus is going to be much thicker than the dorsal ramus. Unfortunately, we don't see a picture here that necessarily demonstrates that. The ventral rami are the structures that can potentially form a network or plexus. In fact, all complex networks or plexuses are formed from the ventral rami. The ventral rami from C1 to C4 form the cervical plexus. The ventral rami from C5 to T1 form the brachial plexus. The ventral rami from L1 to L4 form the lumbar plexus, and the ventral rami from L5 to S4 form the sacral plexus. Now again, the word plexus just means network. So these nerve fibers coming off of the ventral rami, which are branches off the spinal nerves, are recombining and then forming different structures and then branching out and recombining and branching again to finally form specific nerves. Here we have the cervical plexus. The cervical plexus is a network of nerve fibers that are produced by the ventral rami of C1 to C4. Some books include C5. Please don't get caught up in, is it C4 or C5? I usually don't go by numbers. Just know that the cervical plexus is going to be found in the area of the neck, and most of the fibers are going to go to supply the skin of the upper chest, the shoulders, the neck, and the ear. And coming off of the ventral rami from this area, we find the accessory nerve, cranial nerve 11, which supplies the muscles sternocleidomastoid and trapezius. We also see a special nerve here called the phrenic nerve. The phrenic nerve, and this is something I do want you to know, innervates the diaphragm, which is the muscle that helps you breathe, because when it contracts, it moves downward, increasing the area within the thoracic cavity to decrease pressure, so air flows passively in from high pressure to low pressure down its concentration gradient. The diaphragm is innervated by the phrenic nerve that comes from the ventral rami of C3, C4, and C5. We used to say C3, 4, 5, keep the diaphragm alive. The brachial plexus is a large network of nerve fibers that supply the upper limbs, so basically your arms. And the brachial plexus is formed by the ventral rami of C5 to T1 or C4 to T1, or you might see C5 to T1, 2, depending on the book that you read. Please remember, I'm not getting caught up in those numbers. What you can see in this picture, and this is a really great illustration, is that the ventral rami serve as the roots of the brachial plexus. These roots in blue will converge to form trunks. There's an upper trunk, a middle trunk, and a lower trunk that are illustrated in orange in this picture. The trunks will divide into anterior and posterior divisions. The anterior and posterior divisions further divide into lateral, medial, and posterior cords. The lateral, medial, and posterior cords divide into branches, which become specific nerves. So key nerves for the brachial plexus include the axillary nerve, which is going to supply deltoid and teres minor, the musculocutaneous nerve, which supplies biceps brachii and brachialis, the median nerve, which goes to the forearm flexors, the radial nerve, which goes to the extensors of the arm and forearm, and the ulnar nerve, which goes to the forearm flexors on the pinky side, as well as intrinsic hand muscles. The axillary nerve, you can see here a little bit more closely. You can see how in green it comes around here to supply the deltoid muscle. You can't really see the posterior portion of the axillary nerve going to the teres minor. It does. And if there's ever an injury to the brachial plexus, this is sometimes a common injury when people grab onto something quickly to keep themselves from falling. If they're working on something that's high up and they're on a ladder, and if the ladder falls away, they may grab onto whatever they can, and that can sometimes tear the rami of the brachial plexus. So if it's severe, it can either weaken or paralyze the entire upper limb. And again, it's just going to occur when the upper limb is pulled really hard, or if there's a blow to the top of the shoulder, this can also occur. Sometimes if there is a piece of a disc in between the cervical vertebrae that breaks off and sequesters and lays on the ventral rami to the brachial plexus, that can also cause severe pain that radiates down the arm. Next, we're going to look at the lumbosacral plexus. Again, we can see the ventral rami in blue on the picture, and you can see how those fibers form a network where they merge together and then split apart to form different structures. So the lumbosacral plexus, instead of looking at two separate plexuses, we have sometimes books will refer to this as all one thing, a lumbosacral plexus. So the lumbar portion is from L1 to L4. Key nerves that are served by the lumbar plexus include the femoral nerve, which is going to go to the quadriceps femoris muscle group. You remember those are rectus femoris, vastus lateralis, vastus medialis, and vastus intermedius, as well as the obturator nerve, which is going to the adductors. You may remember the adductors, adductor longus, magnus, brevis, pectineus. And then we have the sacral portion of the lumbosacral plexus, which is going to include the ventral rami of L4 to S4. The biggest nerve coming off the sacral plexus is the sciatic nerve, which serves the hamstrings. You remember the hamstrings are biceps femoris and semitendinosus and semimembranosus. The sciatic nerve will actually branch as it travels down the posterior aspect of the leg into a common fibular nerve and tibial nerve. And also from the sacral plexus, we see a nerve called the pudendal nerve, which is going to serve the urinary bladder as well as sexual organs. So the pudendal nerve is important for sexual activity and continence. Here's another look, a closer look at the sacral plexus, where we can get a better look at the pudendal nerve located here. We've got the sciatic nerve, which is this big, thick nerve that travels down, and you can see that just proximal to the knee joint, it's going to branch into the tibial nerve and the common fibular nerve. And then those nerves will branch as well. Dermatomes are segments of the skin that are innervated by sensory fibers of a single spinal nerve. And they've actually mapped dermatomes out. So we've got this map of cutaneous sensation, and there's a lot of overlap of sensation on the trunk. The only spinal nerve that's not included is C1. But dermatomes are often involved in a neurological evaluation where muscles, reflexes, and sensation are tested in that order. So we might test muscle strength from one side of the body to the other, then reflexes from one side of the body to the other, and then sensation from one side of the body to the other. And if there's any difference in the bilateral function, then that could indicate a problem with the spinal nerve at that level. And that's why dermatomes can be important in tools for evaluating the nervous system. Shingles. About 1 million people get shingles every year. 25% of people who have had chickenpox, which are the varicella zoster virus. 25% of those people will get shingles once in their life, and 50% of all people who live up to 85 years of age will get shingles. So anybody who has had chickenpox is basically at risk for developing shingles. What happens is viruses never really leave the body, they just become dormant somewhere. And the herpes varicella zoster virus, and this is a herpes virus, by the way, tends to lie dormant in the dorsal root of specific spinal nerves. Most people only suffer a single episode. However, you can see the herpetic lesions of shingles breaking out, and they usually break out along the dermatome of that particular spinal nerve. When people get shingles, again, it could be due to a weak immune system increasing their risk to activate the shingles, and usually applying a cool cloth to the affected area, wearing loose-fitting clothing, and sometimes taking pain medications can help reduce the pain of shingles. There are some antiviral medications that are available that do help reduce the outbreak of shingles, like acyclovir, famciclovir, just to mention a few.